So thank you everyone for coming, and thank you to Beth and Sonia and the organizers for inviting me to talk about my work. My name is David Zhang. I'm an assistant professor of medicine at Columbia University, and I'm excited to talk to you guys about the clinical telomere testing for the management of interstitial lung disease. Well, in the meantime, I'll go through the background a little bit, which is going to be something that we've heard from, oh, here we go. Okay, so these are my disclosures. Okay, so we heard a fantastic review about short telomeres in ILD yesterday from Dr. Chad Newton, so I'm going to go through this a little bit more quickly. But suffice it to say, short telomeres, whether they're from rare mutations, common mutations, or acquired causes, have been linked to IPF and non-IPF ILD through a body of literature that has shown short telomeres to be, there's a lot of animation, sorry, a causal for IPF and related to mortality and progression, not only in IPF, but also in non-IPF ILD as well. More recent work spearheaded by Chad Newton and Deji Adegunsoya had demonstrated that the combination of short telomeres and immunosuppression leads to a pharmacogenetic interaction resulting in excess mortality, not only in IPF, but also in non-IPF as well. And so telomere length clearly has many roles to play in this disorder. So the question is, why are we talking about it in clinical use for ILD clinic now? Or depending on your point of view, why only now? Well, I would say that now we can consider this a clinically actionable test. Now, IPF is no longer treated with immunosuppression, but that same pharmacogenetic interaction for harm exists in many patients with non-IPF ILD, where immunosuppression still represents a common first-line therapy, and where telomere length could represent a way to risk stratify those with excess risk in exposure to immunosuppression. Furthermore, these patients now have an alternative therapeutic option with the use of antifibrotics reserved for progressive cases. The other reason is that now telomere length testing is clinically measurable. So whereas the body of literature had described this relationship using qPCR measures on biobank samples, we heard from Dr. Mary Armanios yesterday that we have CLIA-certified, clinically validated labs using FlowFish technology. So with that in mind, we wanted to ask, what is the clinical utility of telomere length testing in patients with ILD? And specifically, how often can we diagnose short telomeres in ILD clinic? How do we identify who should get tested? Or another way to ask that is, who is at the highest risk of having short telomere lengths? How does testing affect genetic diagnosis? And more importantly, how does it affect clinical management? So to do this, we performed a single center retrospective cohort study at our NYP Columbia ILD clinic, where we've been really early adopters of using clinical telomere lengths for the purposes I described before. So from November of 2021 to May of this year, we've enrolled about 108 patients with fibrotic ILD that had telomere length testing as part of their routine clinical care. We abstracted clinical records and looked at outcomes including diagnostic rate, genetic diagnoses, and management changes. This is the way that we think about telomere length testing and how to apply those results. If somebody comes in as a new ILD patient, we assess them for indications to test telomere length. The indications I've listed here on the right, these tables include diagnostic indications. These are really signs that tell us that there's a telltale sign of a short telomere syndrome, whether you have a family history of pulmonary fibrosis or a personal or a family manifestation, extrapulmonary manifestation of a short telomere syndrome. As we did this more, we started to expand our indications for testing to include patients where we just needed help to guide complex management decisions surrounding the use of immunosuppression. So if a patient has one of these indications, we perform telomere length testing. And if the testing is normal, then we continue with routine management as usual. But if the telomere length is short, or if there's a family history of pulmonary fibrosis, then we refer them to genetic counseling, we offer clinical genetic testing, and we also, if the telomere lengths are short, we consider immunosuppression with harm, or with excess caution. And I want to take a point to emphasize this. This is not, telomere length test is not the end-all, be-all decider of who gets immunosuppression. We consider this to be just one variable in a complex equation that we use to balance the benefits and risks of immunosuppression. So in many cases, we're using this test as a tiebreaker in split cases where there's not a consensus agreement about the role of immunosuppression. So with that in mind, we had a cohort of 108 patients. We found about 50 patients that had telomere lengths below the 10th percentile, adjusted for age, either in the granulocyte or lymphocyte population, for an overall diagnostic rate of about 46%. This is the sort of demographic breakdown of those who were short versus those who were not. You'll see that there are differences in racial and ethnic background, with non-Hispanic whites more likely to be diagnosed with short telomere length as opposed to their non-white counterparts. I'll also point out that those in our hands, the clinical ILD diagnosis did not meaningfully stratify those with short or non-short telomere length. It does not mean that that does not exist. Our numbers are quite small, but just means to say that if you look for these patients, these non-IPF ILD patients, then you will find them with short telomere length. If you want to enrich for those with the highest risk of having short telomeres, we found that if you had 2 or more diagnostic testing indications, and especially on this bar here, if you have 3, 4, the more testing indications you have, diagnostic testing indications you have, the more likely we are to find a short telomere length. So if you have a family history, you and a family member both had salt and pepper hair by your 20s, and you have multiple cytopenias, then your risk of short telomeres are extremely high. I'll also point out that if you have, on that bar chart on the left, if you have no diagnostic testing indications, as in we tested you just to look for a way to help risk stratify immunosuppression, we still find a surprisingly high diagnostic rate. And I'm happy to speculate why this number is so high. This may be acquired telomere length shortening versus inherited, but the short answer is we don't know, and there's more work that we need to do to understand why that's the case. And if you plug all that back into a multivariable model, looking at relevant clinical and demographic parameters, the things that shake out are non-Hispanic white, CT honeycombing, not definite UIP, but CT honeycombing, and the number of diagnostic testing indications are all independently and significantly associated with the diagnosis of a short telomere length. So what is the clinical utility of testing? We diagnose these patients overall in 46%, and those with more diagnostic testing indications or CT honeycombing are at the highest risk for having short telomeres. I want to take a moment to talk a little bit about genetic diagnoses. Out of our cohort of 108 patients, we had about 30 patients that completed clinical genetic testing. And from those 30 patients, we found 10 variants in telomere-related genes. We have 4 TERTs, 3 RTL1s, 1 PARN, 1 TERK, and 1 NAF1. These were found across the spectrum of clinical ILD diagnoses, although IPF was the most represented with 4 out of the 10 cases. And for the genetic counselors in the room, this is a familiar sight. The reported ACMG pathogenicity class for the most of these were VUSs, or variants of uncertain significance. What that means is that we can't tell the patient if this variant is related to the disease. And that's because the bar to diagnose or to classify a variant as likely pathogenic or pathogenic is appropriately very high. It requires multiple parallel lines of evidence to prove that this variant is important. Well, most of these variants are rare, and if you look at the nomad allele frequency, most of these variants are private, never seen before. So it is most likely that they'll never have the level of evidence to be classified just with that mutation discovery alone. There is one pathogenicity criteria by ACMG guidelines called the PS3, not the video game system. PS3 refers to a well-established functional assay designed to look for or to demonstrate the functional effects of a mutation on the gene product or protein. And so we propose that a well-validated, clinically certified telomere length could fit such a description. And if we apply a threshold of below the first percentile as a PS3 pathogenicity criteria, we propose that we could reclassify 6 out of the 8 VUSs into likely pathogenic or pathogenic. So this has tremendous implications. This means that a family member, a patient may have an answer to why their family is being afflicted by this disorder. This means that we could do cascade testing to test and screen for unaffected relatives who have yet to have the disease. This also opens the door for a lot of complex conversations, I completely acknowledge. But the truth of the matter is there are pathogenic mutations classified as VUS that are hiding in plain sight. And I'd be remiss not to highlight the role of genetic counseling in all of this. This is a flow chart of our patients as they get their clinical diagnosis, as they get their telomere length testing, and then they get referred to genetic counseling. I'll also highlight on the bottom there's quite a few number of patients who get referred to genetic counseling who agree to testing and then are lost to follow-up. But of the ones that completed the testing, we see that we're able to classify 8 out of the 30 as pathogenic or likely pathogenic. And this is a reminder that these are real patients. These are actually 2 of my patients who, after we reclassified their variant, we reached out to their family members. We did cascade testing. We confirmed co-segregation of the disease with their affected relatives, and we identified unaffected relatives who have yet to have the disease. So telomere length testing, we think, can help improve the interpretation of genetic variants and can reclassify up to a significant number of these VUSs. So lastly, I want to talk about how telomere length testing could impact clinical management. And to do this, we looked at medication regimens of patients at the time of telomere length testing and 3 months after testing. And on the Sankey plots here on the right, if you look at the very top, the color represents the medication class that each patient was on. Purple represents no therapy, blue is antifibrotics only, green is immunosuppression only, and red is a combination of antifibrotics and immunosuppression. So if you're non-IPF and you get a short telomere length, you're more likely to be initiated on antifibrotics only, whereas if you have non-IPF and a normal telomere length, you're more likely to be initiated on immunosuppression only. And that's reflected on that table there on the bottom left. And if we do a deep dive on all 108 cases, and we did this through adjudication of these cases by 2 or 3 ILD clinicians, consensus agreement, we can sort of start looking at some of these more nuanced clinical changes, dose adjustments, purposeful avoidance of medications. And if we do that, we can catalog a medication or a management change in about 32% of our overall cohort. And if you break that down by the clinical diagnosis, in cases where there is a more agreed upon role for immunosuppression, whether to use it or not, there's not much management change that occurs. But if you look at conditions where there's no consensus role for immunosuppression, then medication changes, management changes occurred in upwards of 50%. This represents mostly your chronic HP as well as your unclassifiable ILD cases. So to summarize, telomere length testing is feasible. The diagnostic rate for short telomeres is high. It's actionable, and we think it's highly impactful. But of course, the work is not done. We're doing longitudinal follow-up studies to understand how these management changes translate into meaningful clinical outcomes. We did not answer the question of whether or not there is a threshold to decide whether or not to do telomere length testing, and that's a question we should continue to answer. And more importantly, we do have to continue to identify barriers to telomere length testing as well as clinical genetic testing with an emphasis on the patient experience and perspective. But with these shortcomings aside, I hope that our work sort of sparks a conversation about the use of telomere length testing for the management of ILD, which in our view represents an immediately available precision medicine approach to the management of ILD patients. And I agree with many of you in the room after helpful discussions on Thursday that this process needs to be refined. You can't refine a process until you start it, so I say that we start it. So I want to thank everyone for your time, and I want to acknowledge that I'm representing a lot of work done by a fantastic group at Columbia. Christine Garcia, my mentor, Christina Eckhart, Claire McGroder, Shannon Benesh, who are practitioners in the clinic, and our fantastic patient navigators and nurse coordinators, Julie, Suzanne, Denise, Chris Depender, our research coordinator. And of course, Kelsey Boggio, who is our genetic counselor that we refer everyone for counseling, and Joseph Westridge, who helped abstract a lot of the data. And of course, the patients, caregivers, family members who participate in the research efforts. So thank you for your time.
So I know we're going to have a panel discussion at the end for questions, but I know Dr. Zhang has to go to give a talk in another session in a few minutes. So if there are questions for Dr. Zhang specifically right now, I would love to give a chance for them to be answered. Ask now. And maybe while you're doing that, I might just ask, could you speculate on the mechanism of why immunosuppression might worsen outcomes in patients with short telomeres?
Yeah, that's a great question. So, thankfully, Chad did a lot of the work yesterday, sort of highlighting some of these defects. Through a lot of the work discovered by Mary Armanios, there's this sort of innate immunosuppression that occurs with critically short telomere lengths. We've seen that in terms of susceptibility to CMV viremia and pneumonitis in patients who undergo transplant who have these sort of genetic predispositions. And so certainly, there's implications of immune exhaustion when you compound that with intrinsic immunosuppression, that leads to infectious outcomes and so on and so forth.
Perfect. I think I see Dr. Ullman with a question here.
Yeah, thanks. I always have questions. Mitch Ullman, Cleveland Clinic. So is it true that under certain circumstances, telomere length is plastic? And if so, with treatment of IPF, have you had or anybody had the opportunity to repeat telomere length and see if it gets longer?
So we have not done repeat clinical telomere length testing for IPF before and after treatment. I'm not aware of large-scale studies that have looked at that. It is true that there have been studies looking at sort of non-pharmacological and pharmacological interventions to attempt to increase telomere length. I think I don't want to speak for everyone. I think the sort of global concern is that that is sort of a pathway that if you perturb it too far in the wrong direction, it could lead to malignancy and sort of events that you don't want to be responsible for. But I think you're right in the sense that if we had something that could specifically target short telomere patients, that would further bolster our argument to test for these cases and to identify genetic causes.
I think we have one last question here.
Yeah, hi. I had a similar question to Dr. Moore, David. Thank you for the work, David. Incredible work. If you look at if you look at the short telomere lengths, that probably leads to a higher accumulation of senescent cells. And then if you look at the adaptive immune system, it's known to clear those senescent cells, which should help to bring the system back into homeostasis. Question: with immunosuppression, is it possible that you are reducing the cell clearance from the adaptive immune system and therefore not allowing the system to quickly go back into homeostasis, and might that be a functional mechanism? Thanks.
Thank you, Sean. Always hard questions from you, but I don't want to speculate on the specific mechanisms of immune clearance in relation to telomere length. I will say that when we think about telomere lengths here, we're measuring peripheral blood telomere lengths, but we're really trying to estimate a global shortening of telomere length, and whether that is from a germline mutation or whether that is organ-specific shortening. That's something that we don't have the resolution to do that at scale. So there is a lot of interest in sort of looking at senolytics, for instance, to sort of clear out senescent cells, and I think there's a lot of exciting research, but the jury is still out about how that would play a role in terms of the management. Beyond that, I'm going to be speculating, and I don't want to do that too much.
Well, thank you all so much for this invitation. I am extremely honored to be giving this talk today and telling you a little bit about our work, and as Dr. Moore said, about kind of trying to add PET to the milieu of our tools. So this is not the room where I really need to define pulmonary fibrosis, but it just suffices to say it's a difficult disease as a patient and as a clinician to manage, largely because of very limited treatment options. What I want to focus on is the disease diagnosis and monitoring that is currently relying largely on spirometry and HRCT imaging, which of course have very important roles in this process. But one thing that they cannot do is provide functional information about disease activity in real time. They're only able to provide us with retrospective information based on the previous tests. And as you all know and has been discussed, Dr. Kulkarni really presented this well yesterday. PET-CT is used very commonly in other spheres, like in oncology, to give more information about disease function by targeting specific markers of interest. And in that way, it is able to provide better monitoring of disease activity and therapeutic efficacy, both in the clinic, but also during trials, and also is able to provide another layer of personalized medicine where, again, in the clinic, it is able to be applied to treatment strategies for patients, and also able to provide stratifications of different patients for trials. And so, at the moment, for IPF, we really don't have a biomarker that can assess disease activity in real time. And this is really important for improving patient outcomes down the line. So this is the motivation behind our work. And so diving right in, this is an image from an immunohistochemistry slide that was taken from a sample from patient with IPF, where we have a pentachrome stain, and in that we see that in yellow we see the old collagen that is localized to the areas of dense fibrosis in yellow, and then in blue we have areas of new collagen that are localized to very characteristic structures known as fibroblastic foci that are known as the leading edge of new fibrosis. And importantly, these structures, the number of these structures has been previously shown to be associated with disease progression. And recently, a really elegant paper by Herrera and colleagues came out that looked at the different markers within different regions of the fibrotic lung. And it showed that in the fibroblastic focus, which they termed the collagen biosynthesis factory, there's a number of very specific markers that are upregulated very specifically in this region, and one of these is fibronectin. And fibronectin is an extracellular matrix glycoprotein that is highly upregulated in fibrosis and specific to the fibroblastic focus. Moreover, fibronectin co-localizes highly with collagen, and this is an example of that in vitro, in immunocytochemistry image, but also in vivo in the fibroblastic focus, where fibronectin and collagen co-localize, largely because fibronectin actually forms a scaffold that is required for extracellular matrix assembly and deposition, and is thereby kind of preceding the collagen deposition. And so for that reason, due to its localization to early fibrosis and the fact that it precedes collagen deposition, we were targeting this as a potential biomarker for assessment of pulmonary fibrosis disease activity. So of course, in order to do that, we needed a good probe that could actually target fibronectin. And so for that, we actually turned to a 49 residue functional upstream domain, which we termed FUD, of Streptococcus pyogenes, an F1 adhesin. And FUD has been demonstrated to have very high nanomolar affinity for fibronectin. And so here I'm just showing another immunocytochemistry panel where in the top row we see that when FUD is labeled with Sci-Fi fluorophore, it highly colocalizes to fibronectin, which is in white, and then in contrast, the mutant probe, which is not able to localize to fibronectin, shows exactly that. And then in order to improve the deliverability of our probe, because it is a pretty small peptide, we, with our colleagues in the School of Pharmacy, have pegylated our peptide, making a new molecule called PEG-FUD with a 20 kilodalton PEG chain that was connected to our peptide. And we demonstrated, and you see here with ICC, but we also demonstrated with isothermal titration colorimetry that pegylated FUD retains the ability to bind fibronectin with very high nanomolar affinity. And so to just provide just a brief overview, we have shown so far that fibronectin plays a really important role in early ECM deposition, and that PEG-FUD has high affinity for fibronectin. And so we hypothesized that PEG-FUD can target fibronectin in pulmonary fibrosis and can be radio-labeled to serve as a PET-based probe for the disease. So here, because I got a question about this in my poster, I included this little piece of data also. But the first step in kind of demonstrating the ability for our peptide to bind to fibrotic tissue, we incubated both control tissue from a normal subject, a normal tissue, and as well as tissue from subjects with IPF. We incubated it with Sci-5 labeled PEG-FUD, and as you can see on the left, we in the control tissue, we really don't see much localization of our probe, but on the right, you see that in tissue from IPF, we see a heterogeneous level of binding of our probe to the fibrotic tissue. And then further, to look at the specificity of our probe, we utilized a blocking study where in the middle panel you can see that there is, when we pre-incubated tissue with access of our peptide ahead of staining with the Sci-5 labeled probe, we were able to block most of the sites, thereby demonstrating specificity in comparison, of course, to the mutant, which is on the right, that was not able to provide that level of blocking. And so to look at this in more detail, we sectioned the same tissue consecutively and stained with different markers. So we have trichrome stain, which is able to show us deposition of collagen. Then we have a fibronectin stain, and then we have Sci-5 PEG-FUD as well as the MFUD control. And I just want to show you an example of this of one specific region that sort of gave us a little bit more ideas of how to analyze this, where we were able to actually identify a structure that was morphologically consistent with a fibroblastic focus by trichrome, and we do see an increased level of fibronectin deposition in that region on the right upper side. And then very importantly, we see that Sci-5 PEG-FUD does target that region of the fibroblastic focus preferentially compared to maybe other areas. And so in order to quantify this, we outlined this entire lung. In yellow, we have outlined areas of mature fibrosis, and then in black we outlined areas that were consistent with fibroblastic foci, and then we actually transferred those outlines to regions, to the section that had been stained with Sci-5 PEG-FUD, and what we found was that by looking at the densitometry of the Cy5 signal, there was a significant increase in the targeting of Cy5 PEG-FUD to the regions of nascent fibrosis compared to those of mature fibrosis. And then taking this one step further, we looked at the fibronectin stain and again moved all of those regions of interest to that stain. And then found that there was a correlative relationship, a significant correlation between, again, the Cy5 PEG-FUD binding to the level of expression deposition of fibronectin within those same regions. Notably, I will say that the spots that are demonstrated with triangles are actually showing the nascent fibrosis, again showing that high level of PEG-FUD binding in the areas of nascent fibrosis. They also have a lot of fibronectin. And so with this really exciting ex vivo results, we wanted to move our studies in vivo. And so for this, we used the bleomycin model of pulmonary fibrosis, which is pretty commonly utilized in our studies in the field. We used one unit of per kilogram intratracheally delivered on day 0, and then the model progresses through early alveolar epithelial cell injury, followed by inflammatory response, and then profibrotic and mature fibrosis that then self-resolves. So for this, at day 3 and 11, so during early time points post bleomycin injury, we delivered PEG-FUD that was labeled with a radionuclide, which is copper 64, which allows us then to detect our probe with PET imaging. And so we delivered both copper-labeled PEG-FUD as well as copper-labeled mutant FUD, and then scanned our mice in vivo at different time points throughout the next day. And I just want to mention that this was done all in the same mouse cohort. And so what we see here is this is an image example of a micro CT of a mouse. And in the center, you see the lung, which is looking pretty dark because it's full of air, which kind of mimics the air that's on the outside of the mouse. And then below the lung, you see the heart, and above it, you see the spine. So it's laying belly down. It's a cross-sectional view. And so between the normal mouse, which is the normal saline-treated mouse, and the bleomycin mouse, we really don't see much of a difference by micro CT at this time point. And this is when we quantified the amount of signal from micro CT, we also weren't able to detect it by quantification either at the day 3 time point, which really wasn't surprising. This is what we would expect in this model. However, by day 11, and as you can see in the bleomycin example, there is an increase in kind of more of that gray in the lung, which is suggestive of potential increase in fibrosis due to the increased radiodensity by micro CT. And this is something that we were also able to quantify by this analysis of micro CT imaging. In contrast, when we looked at our micro-PET, we were already by day 3 able to see some increase in the localization of our radio-labeled probe in the mice that were treated with bleomycin and our peptide, which is the third image that I'm showing. And that was in contrast with the first image, which is a normal normal mouse that was treated with the same radio-labeled probe, as well as the middle panel, which is a fibrotic mouse that was treated with a mutant probe. And by day 11, that difference remained, where we were able to see increased signal in the mice that had pulmonary fibrosis that was induced by bleomycin and that were treated with our radio-labeled peptide. And And also the final piece of data that I wanted to share was just that we were also interested to know whether the level of radiodensity by micro-CT was able to have any relationship with the probe uptake by micro-PET. And indeed, we did see that there was a correlative relationship between those two signals, suggesting that the more radiodensity we were seeing, the more PET probe uptake we were able to also detect in vivo. So in conclusion, I've shown you that fibronectin plays a key role in development of pulmonary fibrosis, and that PEG-FUD is a good probe for it because it demonstrates nanomolar affinity for fibronectin. And then that PEG-FUD also selectively targets injured and fibrotic lung in ex vivo and in vivo, and that it may thus serve as a probe for pulmonary fibrosis disease activity. So in the future, and supported by the Pulmonary Fibrosis Foundation Scholars Program, I am very excited to determine the temporal localization of our probe throughout the course of bleomycin-induced pulmonary fibrosis, and then also establish its capacity to detect disease activity, predict fibrotic burden, and monitor response to antifibrotic therapy. So thank you so much for your attention, and I really just want to make a couple of notable thanks as well to my mentor, Nathan Stambo, who's a wonderful physician scientist, Thomas Haar and Kristen Stott, who have been working hard on this project with me, and then as well as Haejin Lee, who is from the Department of Pharmacy, who has been working on this project with me as well. Thank you all so much, and of course my funding.
Well, thanks the PFF for the invitation to give the talk. It's a great honor to be here. So it was a little bit background story that provided by Dr. Bernard about this ECM dynamics. She talked about fibronectin, but for me, and today the talk will be specific, talking about the physical property of the ECM. So this gives, what? Oh, yeah. So this kind of gives you a little bit of biological background of the pathogenesis of pulmonary fibrosis. So there are three main cell types that are involved in this process. You have fibroblasts, you have epithelial cells, and you have macrophages. So the current concept, how pulmonary fibrosis initiated and progressed, it usually started with repetitive epithelial cell injury and defective repair, and leads to macrophage activation. Activated macrophages will lead to activation of fibroblasts. And there are crosstalk between each individual cell types, crosstalk between macrophage and fibroblasts, crosstalk between epithelial cells and macrophages. And this also, on this graph on the left side, is also give us a little bit background of some of the compounds that has been previously evaluated or currently in process targeting different pathways in the three different cell types. So a little bit kind of background information about macrophage specifically here. So macrophage polarization or macrophage differentiation are usually been termed into two main pathways. One is the pro-inflammatory pathway where macrophage is usually being activated by interferon gamma. And polarizing into this classical phenotype will generate a lot of pro-inflammatory cytokines, such as TNF-alpha, interleukin-1 beta. On the other hand, particularly in pulmonary fibrosis, macrophage will be polarized into this pro-fibrotic pathway, and they generate cytokines such as YM1, FIS1. In particular, of interest is TGF-beta, which is a main growth factor here. So the background of my research in particular here is we all know that the increasing extracellular matrix stiffness is really a cardinal feature of fibrotic disease in general, not only limited to pulmonary fibrosis, but also liver cirrhosis, chronic heart failure, and chronic kidney disease. So the normal stiffness of a normal tissue on the left side of the scale is usually between 0.5 to 1 kilopascal. But, and most of the time, the experiment we perform in the lab, we usually use Petri dishes, which is at the very end of the scale. You usually have the elastic module almost on the scale of 10 to 100, 10,000 kilopascal. So that's really not replicating what we are doing or physiologically. And so the fibrotic tissue, which is in the middle, usually have stiffness between 10 to 100. And this is kind of the stiffness that we are evaluated here. So first, to validate that the stiffness range that we are observing in a model with pulmonary fibrosis, what we did is we exposed mice to either asbestos or MMVF, which we use as a control. And on day 21, we will sacrifice the mice. So on the left, the green panel you can see is we labeled the collagen tissue with a green fluorescent binding protein. So that's a fibrotic foci that Dr. Bernard just kind of showed in her picture. So you can see that the heat map on the right side, that asbestos has increasing, asbestos exposed mice has increasing tissue stiffness compared to the control mice. So the average of the tissue stiffness in the MMVF mice is about 0.5 kilopascal, as other people have previously reported. However, in the pulmonary fibrosis model, mice exposed to asbestos has a medium stiffness about 35 kilopascal. So what we do next is we fabricate a hydrogel of different stiffness. So the soft gel, which is the blue, we usually use a stiffness of 0.5. And the stiff gel that we use, which is in red, we use a stiffness between 16 to 20 kilopascal. So our group included, cell group has recently studied using conditional knockout mouse model that the macrophage that play the role in pulmonary fibrosis, the predominant of them are monocyte-derived. So the monocyte-derived alveolar macrophages are the main macrophage population that promotes pulmonary fibrosis. During fibrosis, the macrophage, as I previously mentioned, will polarize into this profibrotic phenotype. So here we capture MHS macrophage, which is a mouse macrophage on either soft or stiff hydrogels, and we perform elastin leukemia cytokine production. So in the bottom, you can see on the left side, macrophages are captured on the stiff matrix, producing significant more TGF beta. On the right side, macrophages are captured on the stiff matrix, producing significant more YM1, which is a chitinase. Both are known to be profibrotic cytokines. So next, what we did is we performed research bronchoscopy in IPF patients, and we connect the BAL macrophage out, and we separate them into 3 parts. The gray bar is those naive macrophages from IPF subject. In the middle is we capture this patient BAL macrophages onto the stiff gel, and on the right, the blue one is we capture them on the soft gel. So you can see the macrophages are captured on the stiff gel is able to maintain their profibrotic phenotype almost compared to the naive cells. However, if you capture the IPF patient macrophages on a soft gel, they lose the capacity to producing TGF beta. So this really suggests that stiff matrix promote macrophage profibrotic polarization, but soft matrix actually can reverse this profibrotic phenotype ex vivo. So one of the interests in my lab is looking at metabolism. So we know that macrophage function is closely related to its metabolism. And the pro-inflammatory, the classic macrophage, usually has significant increase in glycolysis, where on the contrary, the profibrotic macrophages that we found in patients with IPF or other pulmonary fibrosis, they usually have attenuated glycolysis. They have changes in the TCA cycle. They also have increasing arginase activity and has augmented fatty acid oxidation. So on the right side, what we did is we isolate BAL macrophages from patients with IPF and as well as healthy volunteers. And we measure the intracellular lactate level, which you can see is reduced in the patient with pulmonary fibrosis. Next, what we did is we performed targeted metabolic analysis by using mass spectrometry looking at TCA cycle metabolites. So on the right side, you can see that specific to the TCA cycle, that patient with fibrosis, their macrophage has reduced citric acid and isocitrate, but they have increasing alpha ketone glutarate, fumarate, and marnate, which kind of showed on the cycle here, which is the TCA cycle. These are all key components in the TCA cycle, but we do find there is a bifurcation that happens at alpha ketone glutarate. So what I want to just briefly mention here that in the kind of metabolic perspective angle is we show that glutaminolysis, which is a pathway that transfers glutamine to glutamate and then eventually entering the TCA cycle as alpha ketone glutarate, is changed in these macrophages. And looks like this change could be modulated by tissue stiffness. So what we did here is we capture macrophages on either soft or stiff matrix, and we perform metabolic analysis and gene expression. So you can see on the heat map the GLS1 and GUT1, both are related to glutaminolysis increased in fibrosis patient. The rate-limiting enzyme GLS1 activity is also increased in the cells captured on the stiff matrix. And on the right side, you can see the glutamate concentration is high in the macrophages captured on the stiff matrix. So this, in summary, shows that stiff matrix can modulate macrophage metabolism towards a profibrotic phenotype. So the mechanotransduction of the ECM, the physical stiffness signaling intracellularly, usually has at least required 2 steps. First, you have to have a surface mechanosensor. Secondly, you have to have an intracellular mechanotransducing pathway, usually involving a sensitive transcriptional factor. Integrin-based focal adhesion complex are some of the most well-studied surface mechanosensors, and they are clinical trials in the past or currently ongoing evaluating integrins. But most of those research are based on epithelial cells and fibroblasts. So what we did here is we exposed mice to either bleomycin or the saline, and then we did a BAL on day 21. We did a flow cytometry and isolate only macrophage population from the BAL cells, and we did a bark RNA sequencing. So on the left side is what we call a volcano plot, and essentially showing different cell expression and their photo change. So you can see that integrin beta 3, the one showed in the red dot, is highly upregulated in mice exposed to bleomycin, which develop a pulmonary fibrosis. And among all the 13 integrins that is changed in this macrophage population, integrin beta 3 has the highest photo change and highest differences. We further validated in the patient populations. On the left side, what we did is we did research 1-copy from normal and IPF patient. We're looking at specific integrin beta 3 gene expression. And you can see integrin beta 3 gene expression is significantly increased in patients with pulmonary fibrosis. On the right side, we further validated with a public available data set, which has 112 patients with IPF and 27 normal subjects. And you can see that integrin beta 3 is one of the highly upregulated gene in the macrophage population. So next, what we did is we silencing integrin beta 3 in the macrophage, and looking at whether this can change the macrophage phenotype. So on the left side, you can see that when integrin beta 3 is silenced, our macrophage has less production of profibrotic cytokines such as integrin beta 3 and retinal alpha, which is FITS1, another profibrotic genes. So next, what we did is we're looking at kind of the downstream gene and downstream signaling pathway in this. So SPP1 or osteopontin is a gene that has known to be highly expressed in macrophage in patients with pulmonary fibrosis. However, how it's being regulated and what's the detailed function still is elusive to us. So what we did here is we exposed the mice to bleomycin or saline. We did BAL and we did a FACS-sorted BAL macrophages, and we perform RNA-seq. So you can see that, again, this validates some of the other people's work is SPP1 is highly regulated in the macrophage population. We further confirmed that with RT-PCR. Also in the patient sample, SPP1 is also highly regulated in patients with IPF. So what we did is we captured the MHS cells on either soft or stiff matrix. So on the left side, you can see that both integrin beta-3 as well as SPP1 is upregulated, suggesting that stiff matrix can increase SPP1 as well as integrin beta-3. So trying to establish a regulation between integrin beta-3 and SPP1, what we did is we silencing integrin beta-3 and we perform immunoblot and RT-PCR when looking at SPP1 production as well as potential signaling pathway. So what we show here is when integrin beta-3 is being silenced, you have reduced SPP1 expression. You also have a reduced ERK activity, which is a kinase in the MAP kinase pathway. So next, what we want to establish is whether this mechanical signaling or matrix stiffness regulated macrophage phenotype change, how does this affect how macrophage crosstalk with other cell types? Here we use, when looking at fibroblasts, what we did is we capture macrophages on either soft or stiff matrix. We take the conditional media out and we capture the fibroblasts with this conditional media and looking at ECM production. On the left side, you can see fibronectin is increased as well as collagen 1. Both are increased when the cells, when fibroblasts being captured with conditional media that derive from macrophages captured on the stiff matrix. So in summary, the schematic here showed on the right side, which is a soft matrix, or in the normal healthy patient, you don't have much integrin beta-3 expression, you don't have much macrophage profibrotic polarization. However, on the left side, when there's increasing ECM stiffness, there's increasing integrin beta-3 expression and activation of the ERK pathway, which leads to macrophage metabolic changes and its phenotype change, which leads to increasing collagen deposition, stimulate fibroblast collagen deposition, leads to pulmonary fibrosis. And I would like to thank my co-mentor, Brian Carter and Yong Zhou. And I think for this meeting in particular, we really want to thank all the patients who participate in our research bronchoscopy.
It is an absolute pleasure for me to share my work, which has been graciously supported by PFF. And my title is a Neuroinnate Interaction in the Pulmonary Fibrosis. So I have nothing to disclose now. So today, I'm going to talk about my background of my study and followed by my hypothesis and the aims. And I will share my preliminary data, which happened since last year with you. And finally, I will conclude my presentation with next steps. So as Dr. Hay already gave you a great overview of this macrophage story, but as we all know that the pathogenesis of IPF is very, very complex. But there have been a lot of studies done to explore the interaction between injured epithelial cells and the fibroblast. But the decades of work by the researchers have identified a macrophage, especially a profibrotic macrophage, is orchestrating this fibrotic process. So first of all, I have to acknowledge Dr. Bethany Moore. She 20 years ago, she reported CCR3 monocyte. This story was kind of base of our study. And also we have to express our, we have to acknowledge Dr. Hay and Dr. Carter's job. And as Dr. Hay pointed out, we usually classify the macrophage into two groups, the M1 type and M2 type macrophage. So M1 type macrophage basically amplifies injury, and that oftentimes suppress the extracellular matrix accumulation and the fibrosis. So M1 macrophage is like anti-fibrotic macrophage, and M2 type macrophage, in contrast, stimulates the post-injury repair, and if that is excess, that can lead to a fibrotic macrophage. So this classification is oversimplified by immunologists, but I think it makes it very easier for like physician scholar like us to understand very complex biology of the macrophage. IPF, TGF-beta1, and macrophage. So as we all know, the TGF-beta1 is another mediator, and TGF-beta1 is a pleiotropic cytokine, so that plays a role in wound healing, and also if it's excess, that can lead to fibrosis in the lung. The previous report demonstrated that this TGF-beta1 can polarize, meaning convert the macrophage to more fibrotic M2 type macrophages. So, and the researchers have identified that there was accumulation of the pro-fibrotic macrophage in IPF lung. So this axis is very important because there could be some potential for future treatment for that. So for example, the reducing the pro-fibrotic M2 mediators produced by these macrophages, such as chitin-3L1, which are reported by my mentor, Dr. Herzog, and also we can repolarize the pro-fibrotic macrophage to healthy macrophage by giving agents such as pentraxin-2. And these studies already led to clinical trial and was led by Dr. Ganesh Raghu over the past decade. And also, I have to acknowledge Dr. Redente's work because the group tested that the TNF-alpha, giving a TNF-alpha pro-inflammatory mediator to the mouse, that mitigated the bleomycin-induced lung fibrosis. So my project supported by PFF is basically focusing on the interaction between TGF-beta1 and the macrophage on lung fibrosis with involvement with a microenvironmental factor. So what is a microenvironmental factor? It's nerve. So especially what you can see here is that in the bleomycin-induced lung fibrosis, in the fibrotic lung in the mice, there is the overgrowth of the sympathetic nerve, the color of some green color filament over there. And the neurotransmitter produced by this sympathetic nerve, adrenergic nerve, is noradrenaline. And the level of noradrenaline increased in a time-dependent manner after bleomycin challenge on day 0. And look at the right side, the figure F, for the translational aspect for human IPF. So we found that there is an enrichment of the noradrenaline in the IPF lung, controlled to healthy lung. So what's going to happen if we suppress the noradrenaline in the lung? So for that, to end this, I generated the sympathetic nerve denervation model by using an inhalational treatment by the 6-OHDA. So 6-OHDA is an oxydopamine, which is a neurotoxic agent which depletes the sympathetic nerve in the lung. So after nerve depletion, I confirmed there's no nerve in the lung. This finding was associated with suppressed intrapulmonary noradrenaline level. And interestingly, in the figure D, there was a suppression of the lung fibrosis after we depleted the nerve. But as you know, the depletion of the sympathetic nerve in the lung is not practical. It's not feasible for patient treatment for that. So that's why I looked up the postsynaptic pathway. So I looked at the receptor of the noradrenaline. So the main receptor of the noradrenaline is alpha-1 receptor. So alpha-1 receptor has two subtypes, 1A, 1B, and 1D. And then over the past 2 years, 3 years, I have found that there was enrichment of the other 1D expressing their cells in a fibrotic region. And morphologically, this is a round-shaped cell. It looks like immune cells, such as macrophage. So then I co-stained with this cell with CD68, a marker. This is a marker for the macrophage. Then I confirmed there was accumulation of the other 1D, alpha-1 receptor cell type D, expressing macrophage accumulating in a lung. So this is the figure D shows this a time-dependent manner after bleomycin induction. So what about in a human IPF lung? So we looked up the human IPF lung by the immunohistochemistry. This is a preliminary image, but we found that there is enrichment of other 1D expressing cells in a fibrotic lung, and morphologically it looks like the macrophage. So the next question is that what's going to happen if I block this alpha-1 receptor? So in these two mouse models, in the bleomycin model, we confirmed that alpha-1 antagonism by the trazocine suppressed the bleomycin-induced lung fibrosis. And then in the figure B show that in a TGF-beta transgenic mice model, this is a doxycycline inducible lung-specific TGF-beta1 overexpressing model. And then the trazocine suppressed the lung fibrosis in this model too. What about in a human? So when I looked up the Yale IPF cohort, which started in 2011, and we included all the IPF patients. So interestingly, the IPF patient prescribed the alpha-1 blocker for non-pulmonary indication. So most of them were taking alpha-1 blocker for the prostate reason or hypertension. But IPF patient prescribed alpha-1 blocker had a better clinical outcome and as well as a better lung function. So that led to my project. My hypothesis is that noradrenaline interact with other 1D to stimulate TGF-beta1 dependent profibrotic macrophage activation leading to lung fibrosis. So I'm trying to test this hypothesis by in vitro and in vivo. So I'm going to share my preliminary data a little bit. So my first question was that what's going on in the macrophage? What is the mechanism going on for that? So then I conducted a single-cell RNA-seq by using the bleomycin model. So this slide is very busy, but in a transcription level, I found that the macrophages are both alveolar macrophage and interstitial macrophage. These macrophages have increased expression of the M1 marker, meaning a pro-inflammatory markers such as TNF-alpha and IL-1B, as Dr. Hay pointed out. This is an M1 marker. So, but in contrast, I didn't find any change in profibrotic markers such as SPP1 or chitinase-3L1 in these macrophages. So this finding was validated by the protein level, measuring the BAL with that from CDE. So this is very easy. So then I decided to look at the macrophage. So I started my project by using the in vitro model. So I used our human monocyte cell line model. This is the THP1 cell line. So figure A and B, I first confirmed this THP1 cell expressed the other 1D receptor. And after that, over the past 1 year, I generated the other 1D knockout cell line, THP1 cell line by the CRISPR method. And then these cells were exposed by both noradrenaline and TGF-beta1. And as shown in vivo mouse model, in the bleomycin model, I found that this other 1D alpha-1 receptor knockout led to increased expression of the pro-inflammatory marker, such as TNF-alpha and IL-1B, figure D. And in contrast, there was a modest suppression of the M2 marker, profibrotic marker, such as chitinase-3L1 in E. And this is associated with modest suppression of the TGF-beta1 canonical pathway. So what about in a mouse model? So over the past 1 year, I generated the mouse model with a myeloid cell specific knockout of the other 1D. So this is the lyse-Emcli other 1D flox mice. So after I confirmed the sufficient suppression of the ADR1D expression in the macrophage, F480 positive cells. Then these are mice are exposed to the bleomycin. Then I found that bleomycin, a challenge, led to an increase of the pro-inflammatory markers such as TNF-alpha in a BAL. Although it was not statistically significant, that's only trend though. And also likewise, I found a modest suppression of the lung fibrosis as reflected by the trichrome staining E and F, and also the collagen amount in G. And also this is associated with the canonical TGF-beta1 suppression. So what I want to conclude is that this ADR1D and alpha-1 receptor, alpha-1 blocker story is very complex. And we found that deletion of this ADR1D appears to result in both anti-fibrotic axis and also pro-inflammatory effects though. So basically, if the inflammation can delay the fibrogenesis, and also inflammation can suppress the fibrogenesis, but also the excessive inflammation can lead to a secondary fibrosis. So I think there is a delicate balance between inflammatory and anti-fibrotic effect of this ADR1D story. So in the future, I have to delve into more biology with my mice, so I'm gonna test my hypothesis by the TGF-beta1 transgenic mice model, which is a less inflammatory model. And eventually, our ultimate goal is the clinical trial testing alpha-1 blocker. But before embarking on that travel journey, we need more data, especially for the safety data, because alpha-1 blocker could lead to more inflammatory cascade. That can lead to acute exacerbation of the ILD. So we need more data. So finally, I came to the US 10 years ago from Japan, and I have been supported to tackle the IPF. We needed to find out innovative therapy for IPF. So, but I've been supported by so many people listed here. And most importantly, my mentor, Dr. Erika Herzog, who is an outstanding mentor at Yale and my role model for the physician scientist. And also, I would like to acknowledge Dr. Maria Padilla, the professor of medicine from Mount Sinai. So when I was a fellow in the Mount Sinai, she really encouraged me and supported me and to back to my science pathway. So without everyone's help, I cannot continue my research. And also, we should not forget the patient effort who donate their biospecimen, who participate in the clinical trial. So with their help, our science cannot move forward. And thank you very much, PFF, and thank you very much.